So first of all, thank you so much, Vaibhav and team 10 of Ophthalmologica for having us here and for giving us a chance to connect and to share some of our cases. And thanks to all my colleagues and partners in this session. Thank you so much for joining us. So I will be starting first. I apologize for this slight shuffle in order. So I'll be talking about my first case of ocular syphilis and how we ended up diagnosing it and the challenges that we faced in this case. This was actually a very big learning experience for me. I'll just share the journey with all of you about what happened in this case. So I'll just move ahead quickly. My slides are stuck. Yeah. So ocular syphilis is actually one of the biggest masquerades in the sense it can present in any sort of a way with any presentation, and it can mimic all forms of uveitis that we know. Why is it important for us to know about it? Because ocular syphilis can occur at any stage of systemic infection. Like I said, it has an ability to mimic different ocular disorders, which can often confound us and lead to a misdiagnosis and a delay in starting an appropriate antimicrobial therapy. And ocular syphilis actually is considered equivalent to neurosyphilis and is treated on the same lines. Now, theoretically, if you look at it, the prevalence or the incidence of syphilis is increasing. And while there was a bit of a dip earlier, in the last few years have seen a resurgence of syphilis in all of our clinics, and the cases that we are seeing are increasing every year. So ocular manifestations can occur in 0.6 to 2% of all patients, and posterior uveitis was one of the most common presentations of ocular syphilis, followed by anterior uveitis and panuveitis. So uvea and retina are the most common manifestations or most common parts which are affected by syphilis as far as ocular manifestations are concerned. You may have a granulomatous or non-granulomatous uveitis, which can be anterior, intermediate, or posterior. But like I said earlier, posterior uveitis or chorioretinitis are the most common manifestations of ocular syphilis. And I would like to share with you some of our cases, but let me just show you the most classic form of syphilis was described way back by Dr. Gass also as an acute syphilitic posterior placoid chorioretinitis, where you can see this placoid chorioretinal lesion at the posterior pole. So if you see that, like what you see in this image, or if you see this photoreceptor damage and this RP nodularity, these are pretty strong clinical pointers towards an underlying ocular syphilis. And this is something which we should keep in mind. So with that background, I'll come to our case. So this was a patient who came to our clinic with a decrease in vision in his left eye. And when we investigated him and when we saw him clinically, there was not much of a significant lesions, not much of involvement of the posterior pole at that point of time, but the OCT showed the presence of a cystoid macular edema. We got the patient investigated systemically. All of his tests, including VDRL, came negative. So he had CME, and if you can see a few occasional cells which can be visible on the OCT over here. The right eye was essentially normal at that point of time. Now, this patient's every single test came negative, including VDRL, and the patient was not willing to take systemic steroids. So we injected the patient with Ozurdex for the left eye. 5 weeks after Ozurdex, the patient now comes with a further decrease in vision in the left eye, which is 20/50. It was the 20/30 initially. And now you can see a small subtle placoid lesion at the posterior pole. But at that point of time, we were not aware of the possible manifestation in this sort of a way. So we were searching as to what could have happened to this patient. We thought we'll observe and see what's happening. And subsequently later on, now at 5 weeks, you can see these multiple small mealy lesions which are there in the inferotemporal quadrant of the left eye. And you can see this Ozurdex implant. At that point of time, when we were going through what could be the possible etiology, we went and checked all of his reports. Everything was negative. But the patient kept on worsening. The left eye lesions worsened within a span of 1 week. And now you can appreciate a small ground glass retinitis also which is occurring. But our VDRL had come negative, and therefore we were not entertaining a suspicion of syphilis at that point of time. Mind you, this was the first case that we encountered. And before that, we had not encountered any case of syphilis. So we were not even thinking of lines of syphilis at that point of time. Though at this point of time, these RP nodularities had started appearing. The patient's lesions kept on increasing, and now we thought that are we dealing with an endophthalmitis that had occurred because of the Ozurdex injection that we have given. We went ahead, did a vitrectomy, sent the sample for microbiology, again negative. Visual acuity now falls to 21, 25. We are kind of alarmed as to what's happening. And now you can see this ground glass retinitis with a central clearing. And now we know better that this is a classical presentation of syphilis. But at that point of time in 2016, we were absolutely clueless about it. And now these multiple mealy lesions have also appeared over here. So at this point of time, now what we did was we went back to the patient, talked to him again, and now he gives us a history that he had developed a small penile lesion a year back, which resolved by itself. And that set the alarm bells ringing. Are we dealing with a Schenker? His vision by now had dropped to counting fingers at 1 meters. And so now we went ahead and got our TPHA done for him. And a TPHA came positive to our surprise. And now when we went back and checked the literature, we realized that VDRL, which is a non-treponemal test, usually has a sensitivity of only around 70 to 75% for ocular syphilis. Whereas the treponemal tests like FTA, ABS, and TPH have got a sensitivity and specificity of high 90s. And therefore, treponemal test is what we should have done earlier. We were misled by a false VDRL, and so we did not entertain syphilis diagnosis at that point of time. And so now we get a TPHA done for every single patient who comes to our uveitis clinic. So that was a learning for us, the fact that there's such a huge amount of difference in sensitivity and specificity of treponemal versus non-treponemal tests. So this patient's TPHA came positive. We now labeled him as ocular syphilis, started him on penicillin. And the moment we started him on penicillin, within a span of few days, the visual acuity started dissolving. Vision improved from counting fingers 1 meters to 2400. Lesions started regressing. 1 week after starting penicillin, vision is 20/60. And now the lesions have nearly completely regressed. Patient finally regained a vision of 20/20 and is maintaining that at the last follow-up also. We also got his wife tested. Both of her VDRL and TPHA titers came negative. So this is how the patient is now maintaining a vision of 20/20. And now this is what we know. And this is what we learned from that case. Multiple small miliary lesions like what you see over here and in this photograph over here. Ground glass retinitis with a central clearing and again multiple mirror lesions, or a placoid chororetinitis are all classic clinical manifestations of ocular syphilis. And if you see any of such presentation, that should alert you to the possibility of an underlying syphilitic uveitis. Apart from that, full thickness retinitis, if you do an OCT through these miliary lesions, like what we see, or presence of, not this is the full thickness retinitis, or presence of an RP nodularity and photoreceptor damage in the area of chororetinitis are again clues to an underlying syphilis. So the management of syphilis is pretty simple actually. It has to be treated on lines of ocular syphilis, is treated on lines of neurosyphilis, and therefore 18 to 24 million units of aqueous crystalline penicillin G for 14 days. And along with that, steroids usually do not have much of a role. We have not given it in most of our cases. So occasionally, if you have got an optic nerve involvement, you can still think of considering systemic steroids, but most of these cases heal by penicillin alone. If you do not have access to penicillin, or if you find the patient has got a history of anaphylaxis to penicillin, then IV ceftriaxone also works well. If both of them are not available, then third choice would be doxycycline 100 milligrams BD for 28 days. It's important to do a contact tracing of partners of patients who need to be evaluated and treated accordingly. Also, it becomes important for us to go back and look at other features. So patients may have skin lesions, and that is something which we should be cognizant of. That again can be a clue to the fact that the patient may have ocular syphilis. And therefore, ocular syphilis, if detected on time and treated early, has got good visual outcomes. HIV positive patients should always be screened for syphilis. And treponemal tests like TPHA or FTA-ABS should be our first line of screening test. So take a meticulous history. Keep your mind open to the presence of syphilis as a masquerade in all cases of uveitis, and treponemal tests need to be done for all of these patients initially to diagnose it. Penicillin is the treatment of choice. Thank you so much. So that was
Hello, Dr. Mudit. Thank you.
Yeah, thank you, Mithali. Yeah.
I just wanted to ask a couple of questions in this. One, that what is the relevance of a VDRL test? Do you recommend to do a VDRL, or do you straight away, instead of doing VDRL, we just shift over to doing a TPHA test?
All right, so good question, Mithali. So VDRL becomes important because it can help you in monitoring the response to treatment. So a definition of a complete cure for ocular syphilis usually is number one, a clinical resolution of the lesions, and number two, a four-fold reduction in VDRL titers. So you use VDRL titers as a monitor to see a response to treatment. That is number one. But for identifying and diagnosing syphilis, TPHA becomes important.
Okay. Thank you. And how long the treatment has to be continuous? It's 10 to 14 days. So after 14
Yes.
days, even if the symptoms are still active, do we continue the treatment, or we do stop the treatment at 14 days? What is your recommendation with your experience in this?
So we have seen till now something around 80 patients of ocular syphilis till now from the last 7 years. And except for probably two, every single one of them had a complete resolution of lesions within 14 days of penicillin. In the only two cases where it persisted, I kept them on doxycycline oral 100 milligrams BD for a month, and that led to a complete resolution.
Okay, thank you so much.
I have a question. Can I ask a question to Dr. Thierry, or there's no time?
Yeah, please go ahead. I think we may have time. I was pretty quick in my presentation, so I
think it's a very quick question. Have you used I mean, I know here that you used Ozurdex, but you were thinking this is non-infectious uveitis. But my question is, have you used Ozurdex in the treatment of syphilitic uveitis?
Never.
After treatment with penicillin. Okay, we have used it in several patients. We had several patients that were resistant to, had macular edema that would never go away after treatment with penicillins. And we've used it, and our view is that as long as you treat the infection, it's safe. It's a systemic steroid. We've published on a couple of cases, but we've used it several times because sometimes we get that type of macular edema that would not go away with anything, including systemic
keep them on a cover of doxy or something, because sometimes Ozurdex, if you give in these lesions, sometimes tend to come back, and those multiple miliary lesions are like classical pattern which you see in a patient of syphilis who has been treated with steroids. So
no, but that's if they are not treated.
Yeah.
So I think there's a big difference, and all the cases reported in the literature with issues with steroids intravitreal were not treated; they were mistaken. Yeah. But these are treated patients. Yeah.
All right. No, my question is that for patients where you have given Ozurdex, you, because of the fact that steroids will have an effect for the next 3 to 4 months at least inside the eye, you have an implant inside the eye. Do you also give them a cover of doxycycline along with the?
No, we do not. We just, the only thing is we make sure that they don't have a reinfection before treating. So we do the serology again and warn them about not to have a reinfection, and we just keep a close on their titer if we have any suspicion.
All right, great. Thank you.
Yeah.
Dr. Mudit, I have recently seen a case of an isolated unilateral disc edema without any other sign of inflammation, which eventually was treated in lines of disc edema, investigated, evaluated. Nothing except a borderline RPR test came out to be positive. But he started responding to steroids and we were keeping him under follow-up. But then he developed a relapse once the steroids were stopped. At this time, again, RPR, VDRL, everything was repeated. And this time, VDRL levels were very high. RPR was also significantly positive. So have you seen such cases where you have an isolated disc edema, unilateral presenting in this format?
A patient who had a disc edema, but he had bilateral disc edema. But then syphilis is a great masquerade. I have had a patient who looked like a TB granuloma, turned out to be syphilis. We published that case long time back. But I have had patients with a bilateral disc edema, and that turned out to be syphilitic. And we treated him with penicillin. This patient was initially given IV MP somewhere else. By the time the patient came to us, it already worsened. And then we started him on penicillin, and the lesions regressed. But if you want to treat if there is an optic nerve involvement, get an MRI done. If there is an optic nerve sheathing involvement there, you will need to give them steroids, but you need to give them under the cover of an antimicrobial. So the point about all retinal infections is that even if you need to give them steroids, you have to initiate under the cover of an appropriate antimicrobial therapy.
Dr. Mudit, I have a question. So,
Yeah.
if the patient is not responding to steroid, and you think it may be infectious uveitis, should we do vitreous stab to send for PCR to find out exactly
So
the?
that depends on the disease that you are suspecting. Now, syphilis is a disease where you don't need to do a PCR or something. You will be able to get a diagnosis just on the basis of serology. So you get a TPH and VDRL done, that should be sufficient. However, if it is a different etiology, if you are thinking in terms of a viral retinitis or a toxoplasma or an endogenous endophthalmitis for that matter, so any of those are cases where you will need a PCR if there is nothing happening, if you are not able to arrive at a diagnosis. There, a PCR becomes important. But syphilis, luckily, is a disease which can be just diagnosed based on the serology.
Yes.
So you don't need a PCR for that.
Dr. Mudit, any alternative to benzyl penicillin, like ceftriaxone group of drugs?
Yeah, I said that if you do not have an access to penicillin, or if you have a patient with a history of anaphylaxis to penicillin, then IV ceftriaxone for 14 days again. Or if you do not even have access to ceftriaxone, then the third line of choice can be oral doxycycline. In fact, there was a paper from Japan which showed that doxy also had a CNS penetration. So they've actually even used it in one case where they could not use penicillin in a case of neurosyphilis also. So if you do not have access to any of them, then as a last recourse, you can always use 100 milligram BD of doxycycline for around 28 days.
Thank you.
So I think that's all. Then maybe we can move to Anirudh.
Yes, thank you, Dr. Mudit. And I think we'll move further to our next talk, which is by Dr. Anirudh Agarwal. He has done his post-graduation from PGI Chandigarh, followed which he has completed his postdoctoral clinical and research fellowship in diseases of retina and uveitis at the Stanley M. Trulson Eye Institute, Nebraska. He's a prolific vitreoretina surgeon with a special interest in uveitis, as well as in imaging of retinal and choroidal disorders. He also has a number of accolades and awards to his recognition, along with more than 200 peer-reviewed manuscripts to his name. I hereby request Dr. Anirudh to please start with your talk on pediatric uveitis. We're all looking forward to it. Thank you so much.
Thank you. Thank you for the kind introduction, and thank you to Team Pan Ophthalmologica for this kind invitation. It's good to see friends, colleagues from the panel. And thank you, Dr. Salam, for allowing us to go first. So I'll be talking about a few pediatric uveitis cases, and I'm going to be talking in terms of imaging and in terms of lab. So I'll divide these cases. These are a few diverse cases that we see in our clinics, and how simple clinical examination, indirect ophthalmoscopy can really help us. So in general, when you have to deal with pediatric cases, we often rely on a good clinical exam and indirect, not so much on the imaging, such as OCTs or OCT angiographies like we do in adults. Here, wide field imaging becomes a very important tool, especially as a screening tool, because in the clinic, sometimes examination may become difficult. B-scan and UBM, which we often don't use in adults, become very important in pediatric cases. So let's go to the first case, which is of a 10-year-old girl complaining of recurrent inflammation, multiple courses of corticosteroids, and she was always thought to have anterior uveitis with spillover. And you can see that this is the vitreous inflammation. The details are not very clear, but this is where fluorescein angiography comes into play here, and it's so important to see the capillaritis and diffuse involvement in both the eyes. And this tells you the level of involvement and the severity of inflammation. She was diagnosed with Behçet's disease, and this patient, was treated by multiple courses of oral steroids. And until you do the fluorescein angiography, you don't know the severity, and only then you can initiate appropriate therapy of biologics in this patient. So apart from fluorescein angiography, even simple photography is very valuable. So look at this patient. Here you have granulomatous inflammation. This patient has been diagnosed with pars planitis. And you can see the fundus appearance over here. It's very classic, granulomatous inflammation. And there are certain aspects that you can see with wide field imaging, and they really help you. Now, you can see here in the periphery, you have kind of a retinoschisis. And this retinoschisis itself is a feature of ongoing inflammation. Sometimes, if you have a very good fundus photograph, you can actually make out if there is presence of a peripheral cyclitic membrane. Sometimes you can see it with the Optos imaging, especially if you don't have a good view on clinical examination. And let's say you're taking up this patient for any surgery. Maybe it could have been a secondary retinal detachment, or the patient could have been taken up for diagnostic or therapeutic vitrectomy. The moment you see that cyclitic membrane on fundus photography, you have a clue in advance, what to expect, and that could be hypotony. So a good view of the periphery is sometimes possible in children. It gives you a good analysis of the retinoschisis, peripheral retinal vasculature, and sometimes cyclitic membranes. If you have snow banking itself is an independent poor risk factor or prognostic factor, especially in pediatric population. Sometimes you have retinal neovascularization, which can be picked up in the periphery. And of course, I already told you retinoschisis and cyclitic membranes in patients with hypotony. So sometimes you have these peripheral granulomas or lesions which are seen on fundus photographs. So unless you dilate the patient, do a good clinical examination, it becomes very difficult to detect these lesions. So simple photographs in these patients become very important. And so you can see there is a peripheral granuloma here, and this was a patient of peripheral toxocariasis. So it's very easy to diagnose maybe the central ones or the optic disc ones, but peripheral may require a good clinical examination and supplemented by photography. I'll show you another patient here. This is a patient diagnosed with JIA, recurrent anterior uveitis for 3 years, and she has been on methotrexate 10 milligrams per week and develops early band-shaped keratopathy. Now, even a simple OCT is enough to diagnose the presence of choroidal neovascularization. In pediatric population, you may not be able to do fluorescein angiography. And so a simple OCT with presence of fluid and this hyperreflective lesion tells you that there is a CNV. You don't need OCT angiography to be able to diagnose. And this patient was treated. And in general, inflammatory CNVs, once they are on immunosuppression and they are treated with anti-VEGF, they usually have a very good response. And this patient was quiet. I mean, there was no recurrence of fluid in the OCT. Moving on, there's another 11-year-old boy presented with the clinical features of Reiter's-like disease. The presentation was questionable and the patient had hypotony. And you can see here, number of synechiae, pigmentation, hypotony. And if you look at the ultrasound here tells you very clearly that you have a serous choroidal detachment, and you know that this is the reason really for the hypotony. So serous choroidal detachments, not very common in Reiter's disease, and so you can therefore change the direction of your investigation in these patients. This patient actually presented with hyphema eventually and fluffy white exudates. And the moment you capture this on the an anterior segment photography, you know that you can dig deeper using a UBM. And UBM, I think, even in the era of anterior segment OCT or pentacam, has its importance to determine the appearance of ciliary body. And here you can see these reflective seed-like echoes, and this is an indicator of a masquerade syndrome. This patient ultimately had a cytology, and this was a diffuse anterior infiltrating retinoblastoma, and the patient required enucleation. Now, this condition is typically in older children. Moving on, lab also becomes very important in pediatric uveitic cases, and especially in patients of JIA, pediatric sarcoid, TB, and TINO. Now, TB itself is a huge topic, but let's focus on more common entities in children, which is, let's say, JIA. Now, this is a 5-year-old girl presenting with early band-shaped keratopathy, cells and flare. Systemically, she's fine, but this is how the anterior segment looks like. So you have these band-shaped keratopathy. it is important for us to ask for ANA. So systemically, these patients often come to us without complaints of joint pains. And when you do an ANA, ANA really is a biomarker for risk stratification. It's not diagnostic. Nobody can tell you the diagnosis of GIA in the clinic. We have to leave that to the pediatric rheumatologist for a complete examination. As an ophthalmologist, it becomes important for us to do ANA as a biomarker. There are certain criteria, clinical, and spending time, sometimes even half an hour with the pediatric rheumatologist to go over the ILR criteria for GIA. ANA value, which is over 1:40, is highly sensitive for uveitis, and 1:160 is very specific for uveitis. But remember, ANA is not standardized, so it's not a diagnostic tool when it comes to GIA. This is a child, 8-year-old boy with polyarticular GIA on methotrexate. And when these children, sometimes they have to undergo surveillance liver biopsy for skin conditions or systemic conditions. This patient was noted to have non-caseating granuloma in the liver and had a NOD2 gene mutation. So this is how the liver looks like, where you have infiltration by interleukin-17 stains. And this patient was diagnosed subsequently with Blau syndrome. So when you have a situation where you have pediatric sarcoid or questionable diagnosis, it is important for us to go back and look at the joint involvement and the skin involvement. This is an 11-year-old boy, and this story is a long story, but to cut it short, this patient had prolonged symptoms, joint pains, fever, beginning for almost a year. And this patient was treated thinking that there is bilateral vitritis, it's a panuveitis, and so it could be TB. The patient received 4-drug anti-tubercular therapy. Nothing happened. Systemic symptoms were as it is. The patient was modified to a second-line ATT with almost 7 drugs, no change. And this patient eventually had a Montu test and quantiferon, which was negative. So sometimes, even in endemic countries, when you believe that this could be tubercular etiology, you have to actually look deeper and then evaluate these patients more systemically. And there was articular involvement of the small joints of the hands. This goes in favor of a systemic disease such as sarcoidosis. This patient had a PET scan also, and this revealed, inflammation or granulomas involving the liver, multiple organs of the body. And this patient was ultimately treated with corticosteroids. And in fact, this is a biopsy here from the liver showing you a non-caseating granuloma. So thank you very much. I showed you lots of diverse cases, and I'm happy to take any questions. Thank you.
Thank you, Dr. Anirudh. There were some really interesting cases. I would now like to open the forum for discussion. Any questions from the faculty or panelists would kindly please, so that we can go forward with the discussion now.
I have a question for Annie. So interesting case with a NOD2 gene mutation. Now, do you routinely do abdominal ultrasound on your pediatric uveitis patients? Would you recommend it?
No, it should be done in patients who have either family history of, it's an autosomal dominant condition. So if you have sibling involvement, it becomes really mandatory, I think, to have at least a screening by pediatric rheumatologists to look at the ultrasound. Ultrasound abdomen also becomes necessary in patients where you have a lineage, coming from certain country. So Scandinavian countries, for example, they have a high incidence of, like from Belgium, they have a high incidence of Blau. So in those countries, it might become important. But routine for all children is not really necessary unless you have boggy joint involvement. There is a series from South India, actually, from Bangalore, where they have Blau syndrome first detected. So it is under-detected for sure. So I think we have to be careful, especially when you have systemic features.
Yeah, so I was thinking, what I routinely do if I suspect sarcoid in children, and sometimes it's just elusive to pin down sarcoidosis in children. And I was thinking, ultrasound might be non-invasive and safe, and could we possibly
an ultrasound abdomen could be very useful in these children, really.
This is what I was thinking. Thank you. Great presentation.
Thank you.
The other point can be in these patients where we are suspecting sarcoidosis, and there's this conundrum regarding Blau is to look at any history of any dermatological manifestations and also a family history. So
Yeah.
we had published a series of 3 cases of blau, which were actually co-managed between us and the rheumatology department of one of the hospitals in Hyderabad. So all 3 of them had a family history. The patient's mothers had the same complaints and dermatological problems. So if you have a conjunction of a family history, dermat problems, then again it becomes, I think, a useful point to probably screen these patients for blau.
Yes.
I have a questions to Annie if
Yes,
time
please.
permits. Okay, thank you. So Annie, I think just maybe one comment, something also we see in the periphery in patients with intermediate uveitis that can be confusing, especially for retina surgeons, or it may come to retina surgeons, in addition to the retinoschisis, is vasoproliferative tumor.
That's
so I think
true.
it might be worth mentioning because they can be there. And again, if it's active, it's an indication of under treatment or needing more treatment. My question to you is just again for the maybe non-uveitis specialists following us now. You have a patient, a kid now, let's say 10-year-old kid or a boy with inflammation in both eyes, and there's panuveitis going on, and before you go down the route of GIA and you're thinking this is needs immunosuppression, do you give them steroids to this kid to test the water, or what do you do? So you have the tests like blood tests for infection, they are negative. Now you're thinking this is GIA like uveitis, even there is no GIA. Before immunosuppress them, would you give them systemic steroids, or what do you do?
Yeah, I think once you have a bilateral disease in a child and you have ruled out infection, with reasonable amount of assurance, then definitely I think systemic steroids would have a role. It also depends on the systemic symptoms, I believe. And so it depends on the nature of the disease. Now, if you have a chronic disease with very mild inflammation, with let's say half cells or just flare, some cases I directly go with immunosuppression. I may not bridge with corticosteroids. Whereas some cases where you have, let's say, a hypopion or very high inflammation, you need to have that bridge of corticosteroids. In my experience, adalimumab takes about 2 weeks to start working. It's faster than the routine immunosuppression. So if you're going down the adalimumab route, you may kind of avoid the bridge of corticosteroids.
No, I think my point was just about like, do you test the water with steroids, and not about like the bridging, just testing the water before you commit them to immunosuppression. Then you find that this was just a weird infection you missed. Do you test the water? Then if they're responding nicely to systemic steroid, you go to immunosuppression, or?
Yes. No, that's a point. Yes, we do. We do test the waters sometimes, and sometimes you have to be very careful in testing the waters. But in children, yes, often you have to do it because sometimes you're limited by so many factors. You may not be able to get infection detected right away. And so you're not sure. You're not really sure. You put them on steroids, you see them frequently. Maybe you call them the next day or after 3 days. We have to do that, yes.
So I have a comment, Dr. Salim. So sometimes when the kids, because in Egypt, sometimes they present a little later and now you can't see really. And sometimes, you give them a bit of steroids in order also to do the fluorescein angiogram and get some info out of it, because you don't want to expose the kid to the dye and then not get enough data out of it. Although, yes, the steroids might suppress the inflammation, but it also, like if it's like half dose, you could get more valuable info from the angiography, my experience.
Yeah, I mean, I very quickly, I think just my view as well, I think systemic steroid is a great tool to test the water in adults or children. I would never test the water with intravitreal steroids because you cannot reverse. We've seen a case where it was syphilis. So I think it's best always test the water, and steroids are not good in children, but as a long-term treatment. But I think it might be good just to test the water when you're not sure. That's my point. Thank you.
Great point.
Just one last question in continuation with the same, bridging the gap with steroids, intravitreal steroids, as you said. But once we have established that it's a non-infectious etiology and non-infectious panuveitis or anterior plus intermediate, would you like to go forward with PST or a transseptal depot steroid for those just 2 to 3 weeks, or is it always better to go systemic, even if it is to bridge?
I've never used posterior subtenon transseptal in children, and I've stopped using it in adults. I feel if you have to inject, then intravitreal is better. Although intravitreal, we have to say, is not approved in children. So in adults, it's a different thing. But to bridge with intravitreal corticosteroids is a viable option. Yes, it is a viable option, especially if you have contraindications systemically. But again, in children is a different story. But I have never used posterior subteno. I think it's just useful for a very limited indication, which is macular edema in intermediate uveitis.
Thank you, Dr. Anirudh. I think taking care of the time, we would like to now move forward to the next
Thank you.
speaker. Thank you so much. Thank you.
Thank you. I'll try to share my presentation. Share. Okay, here it is. Sorry.
Visible now.
All right, excellent. It's thinking about it. So, I mean, thank you so much for Ophthalmologica, and thank you so much for the excellent moderation, and Dr. Gupta, Dr. Kaur, and thank you so much for having me here. My name is Ahmed Salam. I work in Arkansas in the US. So I'll be speaking quickly about vitreoretinal surgery in uveitis. So I'll just give you a brief overview, and also I'll share with you my limited experience in this field. I'm happy to have any questions if there's time. So vitrectomy in uveitis in general can be diagnostic or therapeutic, as we all know, and diagnostic uveitis. Sometimes you cannot see what's happening and you're not sure, and you just want to eyeball what's happening in the posterior segment. I mean, if you go there, you may want to take a vitreous biopsy, and in some cases, chorioretinal biopsies. I just want to show you something very useful. I really love it. And we have a nice video on demonstrating it and how to set up the machine for this. It's vitrectomy under air. And I think when you go down the route of doing vitrectomy, sorry, that was so quick. So anyway, it's on the Academy website, and it just shows how to do how to set up the machine to do vitrectomy under air. And that's really helpful to get a sample and divide it into parts where you can look for infection, bacterial, fungal, viral. Yeah, sorry, it's so quick. Viral and fungal PCR, and also lymphoma flow if you're really worried about lymphoma. And this is just rough figures to remember, which I think the important point to take from here, that if you're suspecting viral infection, you do an aqueous or vitreous PCR, is negative, it's very, very unlikely it will be viral. And I think this is very useful to know. It's not the case for toxoplasma, though, but I think the first part is very useful to know. Okay, and sometimes you need to do a chorioretinal biopsy. I'm not sure why it's going so quickly, but okay. So sometimes you need to do a chorioretinal biopsy. This is a patient who had a very weird infection or lymphoma we were suspecting that completely wiped off the retina. And when we took a chorioretinal biopsy at the end, we found actually it was a very unusual toxoplasma, and his aqueous and vitreous before was negative for that. It's always important to make a big opening to take this out, because otherwise it will keep falling as you take this out. Okay, now next point is there's another patient who had these lumpy lesions, and again on chorioretinal biopsies that was found to be a B-cell lymphoma. Now the next indication is the using the vitreous as or doing vitrectomy for therapeutic reasons, and that can be classified under inflammation control, management of complications, or using it as a sustained drug depot. So inflammation, the question is, what's the role in infection? And then the next one, what's the role in non-infectious uveitis? And then this may include also retained lens fragment matters. Complications, we all know it can be used for vitreous opacity, ecretinal membrane, retinal detachment, and as a sustained drug release. For infection control, I'll just give you here my thinking. I think the endophthalmitis vitrectomy study showed very nicely many years back that intravitreal injection of antibiotics is just enough. And I know that this does not happen now. Many surgeons go for vitrectomy early on. So we did a study from the European Vitreoretinal Society members where we looked, okay, what happens now? And we found what we expect. Most of the 75% of retina specialists go for vitrectomy, regardless of the vision for acute endophthalmitis. But what were the results? There was no difference. So again, we replicated so much the results of the endophthalmitis vitrectomy study. And there are several meta-analyses out. So I think the message on this is just inject the patients quickly, then later on vitrectomy if need be. But I would not really wait and waste time for waiting for vitrectomy. I think it's useful. Is it useful for fungal infection? It is useful, but again, we found that it decreases the risk of retinal detachment, but it does not improve the vision, even vitrectomy for fungal infection. Sometimes you need it for a persistent lesion like this one. This is my coolest ever video, where you have this lesion there that that ended up being a fungal mass that we removed. Sorry, not sure why it's not working, but anyway, it's a fungal mass that we were able to work. Now, moving to the next one about inflammation control. So the $1 million question is doing vitrectomy helpful to control non-infectious uveitis? Meaning that can we decrease the medication after vitrectomy? So do vitrectomy to decrease medication. And there is this paper in intermediate uveitis from the Foster group, but my answer to this is a finding again of a meta-analysis and also different literature. There's no proof for this. And because most of these cases, they had intravitreal kinologue, they had cataract surgery, it's very difficult to prove. And I think the saying, at least from my understanding, I don't think vitrectomy decreases the need for immunomodulation. Vitrectomy does have indications, as we are discussing now, but per se, it does not decrease the need for immunomodulation. That does not apply, of course, for something like retained lens fragment, where vitrectomy is very important to decrease inflammation. My always advice in these cases is to clean well, because here you think after removing this lens matter that there's not much, but you find out that this is a very big lens matter. And the reason why these eyes remain inflamed is because you leave lens matter either in the capsular fornix or in the periphery. So very important to clean well. Can it be used for treatment of retinal detachment? Yes, of course. You may use gas or oil. Just a point here. Usually breaks happen at the edge of the necrotic areas, or laser scars if you've lasered before, like in this case. And sometimes cases can be difficult and you cannot find the break. This is a patient after acute retinal necrosis and we really could never find the break. I'm not sure why the videos are running quickly, but I think the message is it's usually at the edge of scars, the breaks, where the breaks are. This is an interesting case. I'm sorry, my videos got jinxed for some reason, but anyway, this is an interesting case of a patient with retinal detachment and a choroidal detachment. And we were not really sure what does this patient have. The history is that patient is immunosuppressed and had bone marrow transplants for leukemia. So we felt that it was rhegmatogenous detachment. Again, a point here, when you have a choroidal detachment, you go with the trocars anteriorly, going like directed towards the ciliary body and not directed towards the vitreous. We hope too much going on, so let's just take an aqueous sample. Then we went to the back of the eye, and then we saw really what was very interesting is that, as we can see here, there's this area of healing retinitis. And next to it, there's a Schleren coming. So this was the money shot that we know that this is rhegmatogenous detachment for sure. And the second point, if this patient had a very mild retinitis, it's either toxoplasma or CMV retinitis in immunosuppressed host. So we ended up doing a drainage retinotomy. The break was severely, so we just left those choroidal undrained and put gas bubbles 30% to 6, and we had the retina flat. And this echo sample showed that this patient had CMV retinitis as a result of immunosuppression. And then again, patients with hypotony, like this patient, had all the steroid injections in the world, and we ended up doing vitrectomy silicone oil back in 2016, and to try to put the pressure up. But as you see here, this is a graph of the pressure. Just after the surgery, the pressure went up for just a bit, and then it went back. So I think the message for this, putting oil in the hypotenuse eye does not raise the pressure permanently. Actually, on the contrary, you're facing the problem of getting the oil to come to the front of the eye because there's no aqueous secretion. So I don't think really it's a good point at all, putting oil to raise the pressure. And finally, you can use it as a sustained drug release depot, the vitreous, putting medications in the vitreous, and that's the list here of medications that can be put in the vitreous. And we like dexamethasone during vitrectomy surgery. At the end, you have to be careful because it shoots very quickly. We usually don't see injuries. We had a case who had hemorrhage, but no injuries. But I think it's really nice, and it controls the inflammation nicely. Or you can go more hardcore and suture a Retisert implant. And we sometimes do this. The problem is it's so expensive, so you don't want to do like what I've done here in this case, because it's only $20,000. You know, it's not, it's a bit cheap. You don't want to do that. Oh, you don't want to lose the implant. Okay, and again, you can use it also for medications, anti-infective medications. I'll run very quickly. I think I can show you the video for the vitreous biopsy. I hope it works. Okay, here it is. So you prime the machine under air, and you'll be surprised how much fluid is there you'll get out. Then we connect even the air temporarily to the cutter to flush the cutter. And again, you'll be surprised how much you get out of the cutter there. And now everything is dry. And then you can use this to take the sample. So you reconnect, this is under air, you have the syringes here. And now this is the view from outside, and you can do 3 syringes. That's what we usually do, 1 for bacterial and fungal, 1 for viral and toxoplasma PCR, and a 3rd for flow. And I'll show you how what happens. The nice thing is that you can take a very big sample, up to 2 ml of neat vitreous. The eye does not collapse. When we do it under closed infusion, the eye collapses and you can hit the lens, and you also limit it in the sample. So that's what happens here. You keep going down and the air is filling, and then after that you shift to fluid. And this video is on the Academy to just show you how to set up the machine. That's the only part really which I think is interesting. Well, thank you so much. I'm sorry that the videos were not playing well, but I think we got there. Thank you.
Thank you, Dr. Salam.
Thank you.
Just wanted to know how frequently do you feel the need to do a chorioretinal biopsy in a case of lymphoma?
In a case of lymphoma, I think the vitreous yield, and again, I think might be a nice number to know. I think if you stop the steroid, you use a bigger vitreous cutter like 23 gauge, and you do vitreous biopsy under air, and you have a good pathologist, I think the yield is in the 60–65%. If it's still negative and you're suspecting, I think this is where you go for a chorioretinal biopsy. So I think rare.
Rare. Okay.
Yeah.
Okay.
So can I make a point here, Mayur?
Yes. Yes.
Yeah, so I think the one important point is what Dr. Salam also mentioned. The fact that you ideally should ensure that your patient is not on steroids at that point of time, because that is going to confound your results. So you have to ensure that at least for 2 weeks before you have to, on the day of taking biopsy, before that, prior to that, at least for 2 weeks, the patient should be off steroids, because otherwise that will affect the lymphocytes, and then your yield will not be as good as what it should be. That is the first point. Secondly, it also depends upon the level of involvement. If you have got a huge amount of vitreous cells in a lot of vitritis, then in these cases, a vitreous biopsy in itself, in a lot of times, will have a higher yield. However, if you do not have significant cells in vitreous and you have predominantly subretinal lesions, then a chorioretinal biopsy or taking a biopsy directly from the area of the lesion may be more helpful in increasing your diagnostic yield. There are papers and surgical techniques published by different surgeons, including Vishal Rawal and Mohit Dogra, and from the Shields group also, where directly taking a needle into the subretinal lesion or the lesion which you are suspecting of as a lymphoma and then aspirating that in itself can lead to a better yield. So that will also depend on the clinical presentation that you have, which will help you in deciding what sort of a sample or biopsy you are going to do.
Okay, thanks, Madhur. Are there any other questions from the panelists? Namrata, can we move
So
on
if
to the
there are-
next speaker?
So if there are no questions, to continue the learning further, I'll welcome Dr. Deena Badar, who is a medical retina and uveitis specialist in New Cairo. She's a clinical researcher at the Research Institute of Ophthalmology. She's a board member of EGVRS, Northwestern University, the Feinberg School of Al Watri Eye Hospital, Cairo. So please, ma'am, we are honored to have you here. You can take this.
Thank you very much, and thank you for staying with me. Thank you, Team Pan Ophthalmologica, and it gives me great pleasure to be here among new friends and old ones like Dr. Salem from Cairo. So my case is pretty straightforward. I think the title gives it away, right? So this is a 38-year-old healthy gentleman who came in with a history of floaters and drop of vision in the right eye. And but he has had binocular diplopia 20 days before the ocular symptoms. As you can see in the pictures, he had those, first of all, the vision was in the right eye 0.8, in the left eye 6.6, but we can see those patches of retinitis in the periphery of both eyes, actually with vascular sheathing in both eyes adjacent to patches of retinitis. Now, this is a scary thing to see in your clinic, and then we confirm this. Like, what sometimes sometimes in such a case you don't need to do angiography. But what I do is that I look at the green channel on the Optos images, and it gives me a better view of what's going on in the retina. And when we do our OCT, we can see the inflammation surrounding the vessels in the macula. So, but there's not a lot of macular edema. But there are inflammatory cells, but not a lot of macular edema. Now, what I do, because we do our images ourselves, is that I go to the lesions and I scan the lesions on OCT. Although the lesions in the right eye were not telling me a lot, like only the inflammatory cells in the vitreous, but the lesions in the left eye were more telling. We could see that the inflammation affects all layers of the sensory retina. And but the choroid looks thickened, but like you can tell that the RP is quite intact. So we work up a patient like any uveitis patient, and this patient had been worked up for viral levels, and they came back for immunoglobulins. The VZV and the CMV were positive. I don't routinely ask for immunoglobulins, but he had been worked up in the community before being referred to me. And he also showed a CT chest, showed this enlarged thymus gland. Now, I didn't know what that exactly means. So what I did is that I referred the patient to cardiothoracic surgery, actually 2 of them. In the meantime, because I could find the VZV and the CMV high, and I knew this was a viral retinitis, I started him on loading dose of valganciclovir. Now the patient comes back, the lesions regressed a little, but they appear more coalescent in the periphery. And I also was consulting with cardiothoracic surgery regarding the thymus, but they did not see a reason to treat or to biopsy. They said this is just an essential type of thymus gland, persistent thymus gland. So although the patient was doing well in the left eye, I was not happy about the right eye. So I went in and got an AC tap. and I gave ganciclovir 6 milligrams in 0.1 milliliters. Now, this when I looked at the PCR, they came back for varicella, which is typical, but I had to shift this patient now to infectious disease. Like I wanna co-manage this patient, and well, we spoke on the phone, and we decided that Valtrex is a better antiviral treatment for varicella. The patient was developing more lesions in the periphery. I don't know whether they had been there before. I looked through the images, but obviously these are new lesions. So this is why I was dealing with a case of bilateral ARN with secondary to VZV, and I was more comfortable, more happy to be following up this patient with infectious disease. So this is a patient now on Valtrex. He does much better on Valtrex. I did continue to do the ganciclovir injections for the right eye, and 2 weeks later, the patient is doing much better. So we go for the third injection. 3 months later, the patient comes in and he has developed haze in the right eye. Not so much is happening in the left eye, but only the right eye has developed haze. But like none of the retinitis, none of the vasculitis is flaring. So I'm thinking, what's going on? And also typical of viral diseases and viral retinitis, he developed a detachment in the inferior periphery. The detachment was shallow and it was not threatening his vision, but he only had the haze on top of the detachment. So I decided, I consulted with VR, and they didn't think there's a need to do surgery because it's insidious, it's inferior, and the patient had been doing well so far. The vision was 6.6, and I agree. So we kept the patient on maintenance dose, valacyclovir, but I started him on systemic steroids, and he does extremely well, which goes with the same discussions that we were talking earlier about infectious uveitis and when to introduce the steroids under cover of antimicrobials. So what happens basically is some sort of, I wouldn't say an immune reaction, but I think that there's an infiltration of the vitreous with those inflammatory T lymphocytes, and these are in the vitreous only. They're not an active, there's no active virus or microbe in there. It's just an inflammatory response. So what I learned from this patient is the features of infection. Like I go and do the cuts for myself and make sure that I'm not misdiagnosing, like I'm not missing anything and this is not toxo. The other thing that I learned is that valganciclovir does cover VZV infections, and it has, of course, an anti-herpetic activity. But although it's more famous to work in CMV infections, basically because triple phosphorylation of the nucleus happens in CMV, and hence it becomes more potent and better inhibition of the replication. So thank you very much for your attention, and I'm happy to take your questions.
Ma'am, what are the criteria for giving intravitreal ganciclovir?
So on this patient, because I was misled by the high immunoglobulins. So I thought is this possibly a CMV retinitis? What's going on with the thymus? Like I was misled. I was thinking maybe this patient is immunosuppressed, and then I started the injections. But when we did the injections and he did so well, he insisted on getting the injections, and I was seeing some kind of improvement. We gave a total of 3 injections.
And did you start steroid after starting antiviral, or you first?
So in the first episode, the patient, when he presented, we did not need to use steroids at all. Like we were only using antimicrobials. But when he developed the vitritis, which again, I think was just an inflammatory response, like no actual infiltration from the virus, and he responded really well to systemic steroids. And eventually the patient moved to Saudi Arabia. I left him on like 10 milligrams of steroids, and I put him in the good hands of our friends and our uveitis colleagues in Saudi Arabia.
Can I ask a quick
What did you
question?
do for the right shallow RD?
Sorry, go ahead, Dr. Gupta.
The other eye shallow RD which you managed.
No, so we're only monitoring with serial imaging. So we did not actually treat it, but we took serial images of it. Dr. Salem, you have a question?
Yes, if time permits, Dr. Gupta, can I ask a question? So do you have a vitreous biopsy, vitreous PCR?
On this patient? Yes, we did.
And sorry, maybe I was daydreaming at the beginning, and it was negative or positive? Or...
No, it was positive for varicella. So what happened is that he came in with the immunoglobulins. So like this kind of fooled me, right? Because he came back with he was referred with the immunoglobulins high on VZV and CMV. And he also had the thymus gland enlargement. Was that reactive? Was something happening that I was missing? So until it was time to come back and do the vitreous biopsy, because I wanted first to have like a safe, I wanted the cardiothoracic people to look at the patient first before I give, before I do the PCR, like act safe, get the body covered really, and then we'll schedule for a PCR.
Yeah, you can always do that. Also, aqueous yield is very good.
I do on the aqueous. I don't go for the vitreous. I mean, I'm not a trained vitreoretinal surgeon. I do on the aqueous, and the yield is great. But we don't do it on the slit lamp. We actually have to take the patient to the OR. Okay, any questions?
In this patient, like there was no optic nerve involvement or posterior bone involvement. So do you directly go to the maintenance dose, or you give first induction and then?
No, the patient was on induction for Valtrex. Like he was 2 grams TID for 4 weeks, and then we reduced it.
How long do you continue the maintenance dose?
So this was under the help of the infectious diseases. They wanted, like, they were thinking about 3 months and then tapering, but eventually the patient had to move. So I am not sure what dose he's on right now.
No, like in general practice, a patient of like ARN or whatever, what maintenance dose, up till how months do you continue the maintenance phase?
It largely depends on the patient, and I know like we don't have our own data. Like we use the data from the cornea people. I usually maintain patients for 3 months, and then I monitor. I have had patients relapse, like I maintain them for 3 months, and then by the 4th month they relapse. So it's a case by case. I usually do it if the patient has had a relapse within a year, then you continue for a year of treatment. But I do a 6 months to a year basically.
So, Dr. Dina, just one more question. So, whenever there's a relapse, do you do with the same medication, or do you change to maybe famciclovir or foscarnet, or do you continue with valacyclovir for ARN?
So the relapses that I've seen were usually in the anterior uveitis people. Like I've been lucky, like the posterior, the retinitis people, I have not seen a relapse. Maybe Dr. Salem has more experience, but for the anterior uveitis people, what happens is that I never go from like 5 acyclovers to 0. I stopped doing that. I started doing that, but then I immediately found relapse, whether in the cornea or in the anterior segment. So what I do is that I go, like through 3 first, and then I monitor him for about 2 weeks. And then I see how it goes. Like usually I keep them on 3 times a day, like for 4 more weeks. And then I do BID and watch them. Also, you have to keep the Kiryat in mind. Like I always get the Kiryat every 4 to 6 weeks.
Thank you. Very interesting case. Thank you, ma'am.
I think maybe quickly, just also give them advice to drink lots of water because they can go into acute kidney injury. And that's what the renal people say. They say water is the very important. Just lots and lots of water, especially when they're on a high dose.
Great, thank you. So do we have any more speakers that will be at this session?
No, I think this brings us to the end of this session, and we'll be beginning with the second session, which will be moderated by Dr. Avnish and team. Thank you so much, everyone. It was a very interesting session.
Thank you.
Thank you. Thank you,
Excellent
Dr.
moderation.
Salam.
Thank you
Thank you,
so
Dr.
much.
Dilip.
Excellent.
Thank you, Dr. Mudit.
Yeah.
It was so
Thank you.
nice meeting everyone. Thank you so much.
Thank you, everyone.
Lovely.
A very warm welcome to everyone. That was a very exciting first session with very interesting talks. So we have a second session now, equally interesting, with very eminent speakers. We have Dr. Peter Kaiser, we have Dr. Umesh Behra, and Dr. Muhammad Al-Amri and Dr. Ashish Sharma. So I would request the respective moderators to take on and conduct their respective talks. We would try to stick to the timings in this session. So may I request Dr. Bhavani to start conducting her first talk by Dr. Peter Kaiser, please. Thank you.
Good evening, everyone. Unfortunately, Dr. Kaiser is not with us. So, but he was very kind to send his presentation. So I'll be playing video of his presentation. So Dr. Kaiser, everybody knows that he's a faculty of Cole Eye Institute at Cleveland's main clinic. And he's actively involved in multiple researches. He's the principal investigator and chairman of 4 major multi-center clinical trials. He's the editor at the multiple journal like Retina Today, Retina Physician, and Ocular Surgery News. He has been awarded as the Best Doctor in America list. So I will be sharing my screen.
Do we have the audio, Dr. Bhavani?
No.
I think there's a problem with the audio. I think we don't have the audio, Dr. Bhavani. Would you like to reload the presentation or something? Otherwise, we should move on to the next speaker till we sort out.
Because I cannot hear anything.
Is it not audible?
Yes.
Yeah, that's exactly what I'm telling.
So we
Video
have.
quality is not coming.
Yeah, please stop. There are audio in PPT now.
Yes.
At the bottom side, there are view option. उसमें एक more करके है, उसमें share sound है. Stop share के ऊपर there are many options. No problem. Click on share screen, then click on screen, then click on share sound. At the bottom side, share sound on that window. Yeah. Now
Technology shows that the complement cascade is very involved. So it makes sense to target this cascade. So how have we done that? Well, one way is to target C1q. Now, I told you originally that C1q was activated by antibodies, but as you can see, there are many other things that can activate C1q, in particular C-reactive protein, as well as amyloid beta. We know that amyloid beta is found in drusen. And if we look at C1q accumulation, we see C1q on drusen as well as around areas of geographic atrophy. So because of that, it makes sense to use an inhibitor of C1q to prevent some of the neurodegeneration at the level of the photoreceptor. And ANX007 binds C1q. It's a Fab fragment intravitreally injected. So if we look at the Archer study, which was a phase 2 study using intravitreal ANX007 either monthly or every other month, the primary outcome of this study, interestingly, was not met in terms of reducing geographic atrophy progression. However, one finding that came out of it, which we have not seen with any of our complement inhibitor studies, is that from a functional standpoint, a 15-letter loss of vision was prevented in the patients receiving ANX007, especially when given monthly. Now, this is a regulatory approvable endpoint, and so because of this, this drug is moving forward into phase 3. Since the alternative pathway is the most active and one of the key factors within the alternative pathway, which is involved in the amplification step, is factor B, Ionis, as well as the licensee Genentech Roche, has developed a subcutaneous inhibitor of complement factor B. So this is a subcutaneous injection of an antisense RNA that prevents the formation of factor B. And this is currently being tested in a phase 2 clinical study with sub-Q injections every 4 weeks. And this study is fully enrolled, so we hope to see the results of this study shortly. Now, complement factor D is also the rate-limiting step of the alternative pathway. And we had a very large clinical study by Genentech Roche using an intravitreally injected factor D inhibitor called lampalizumab. This failed to meet its primary outcome in a large phase 3 clinical program. However, other companies are looking to target factor D, including Alexion, which is currently in a large phase 2 clinical study. Now, I mentioned to you about complement factor I and complement factor H, which turns off the alternative pathway. We know that complement factor I is strongly associated with macular degeneration. There have been studies looking at amplifying complement factor 8. So as opposed to the rest of the complement cascade where you inhibit it, in this case, we're trying to return recombinant or normal factor I to the body to prevent the perturbation. Unfortunately, however, the gyroscope study, which was a gene therapy program to deliver complement factor I, has failed. Other companies are also looking at the idea of giving recombinant factor H, more importantly through gene therapy, to allow us to have a long-term production of complement factor H, and these studies are ongoing. Now, the first area where we had positive phase 3 studies was in the inhibition of C3 and the production of C3a and C3b. And this was using pegcetacoplan by Apellis. In addition, other companies are also targeting this idea of being a little more targeted at C3b, because C3a may have beneficial effects. It's really C3b, which is what we want to target. But in a Derby and Oak study for Apellis pegcetacoplan, patients in the phase 3 clinical programs had a reduction in GA lesion growth that was especially evidenced between months 12 to 24, as well as thereafter in the GALE extension. And based on this drug was approved by the US FDA and was actually the first drug for the treatment of geographic atrophy. Other companies are looking at this idea of blocking C3, including Innovent, which has a fusion protein that blocks both VEGF as well as complement. In the phase 2 wet macular degeneration study, it had comparable outcomes to aflibercept, but the hope is to reduce fibrosis and to reduce atrophy with a single intravitreal injection. Phase 3 studies will be starting shortly. The second area where we saw a positive phase 3 was blocking complement factor 5, so C5. Now, there were some early studies that failed. However, avacincaptad pegol from Iveric Bio met its primary outcome in a phase 3 clinical program called the GATHER1 and GATHER2 studies, where patients were treated either monthly or every other month in the second year of the study. The results showed a statistically significant reduction in GA lesion growth both at 1 year, and the 2-year results will be presented shortly. Now, an interesting thing about the Iveric Bio program is that when we look at patients who progress from drusen to Aurora or Cerora, as you'd expect, not only was the progression of GA reduced, but also there was a reduction in basically early or Aurora, so before geographic atrophy occurred. Now, the formation of the membrane attack complex is the final common pathways for these drugs, and a soluble CD59 prevents the formation of the membrane attack complex. CD59 has been shown to be reduced in patients with macular degeneration, and this may be one reason why these patients are developing geographic atrophy. So a company has used a gene therapy program to produce soluble CD59, and this has been shown to reduce lesion growth in phase 1 studies. Phase 2 studies are currently being designed. So in conclusion, dry macular degeneration is a uniquely human disease, so the only animal model we can use to test our drugs are humans. There are many strategies to target the complement system with many clinical trials underway, but thankfully and finally, we now have 2 approved products to treat GA progression. Thank you.
We thank Dr. Kaiser for the wonderful talk. It is open for the discussion. Our esteemed faculty who have experience about this complement inhibitors in cases of age-related macular degeneration, what are their opinion and their experience? If anybody wants to share. So all these medicines are still under phase 2, phase 3 clinical trials. I think there is a long way to go for complement inhibition and their active role. So till now only 2, the pegcitalopram and avacincaptad pegol are the US FDA approved, and they are showing reduce in the progression of geographic atrophy. But still in those studies also, the visual gain is not that much, but at least it is reducing the progression. So anybody wants to add anything?
The only question that is that we should ask that why again, we could not pick up the signals of vasculitis in the trial with Syfovir. Again, the same thing what has happened with brolucizumab, same thing is being repeated here. And it again got picked up only in the real world. And you see now back-to-back cases of vasculitis, and that too, quite strong vasculitis. So I mean, somewhere we are not sure. We have given some of the hypothesis in terms of the anti-drug antibodies in cases of brolucizumab, but here things are a little different. There's a complement, so means probably the good complement, as Dr. Kaiser said, means good complement, which probably is quite upstream. That if that saves a lot of things, that clears out a lot of things, which if they are not clear, then probably that gets deposited and causes occlusion. So it's unfortunate. Means therapy was good, results were good, but still we could not pick up them all of them in trial.
Right, and few of the trials showing that the complement inhibition can lead to more conversion from dry AMD to wet AMD because it is increasing the neovascularization, but it is still not proven.
Yeah, means that natural history means nobody can predict that whether that's happening because of the natural history or means that's just
because of the drug.
Yeah, but yes, it was a little more more in the test arm, so means we cannot deny it as well. So that's true, but still for wet AMD you have treatment and these patients are ongoing on medication. So if you detect conversion, then at least you have a chance to treat.
And so despite excitement surrounding the use of this complement inhibition to treat the geographic atrophy, there are numerous questions yet to be answered, and we are looking forward for the bright future for geographic atrophy.
It was so fascinating. If you look at these just 2 molecules, one showed inflammation with vasculitis, with occlusion. Other one, if you look at, it was just clean like a glass, even in trial and then even the real world. So you can imagine the difference and the role of those upstream complements, how important they are in terms of clearance of what kind of inflammation debris that you have. Means that's what the understanding we have at this point.
Right. So thank you for the discussion, and we'll be moving to the next topic.
Thank you, Dr. Bhavani. Thank you for conducting it so well. And I request Dr. Duk, kindly take over for Dr. Umesh Behra's talk. Thank you.
Okay, so we're moving on to the next, our next speaker of the day, Dr. Umesh Behera from India. So he's going to show us a very promising way to treat chronic CSCR. On to you, sir.
Thank you, Duke. And it's a privilege to present in this nice symposium. And thank you, Pan Ophthalmologica. So let me take you through one of the recent research which we just published and we are still working on. That's about use of steroids in central serous chorioretinopathy. And traditional teaching is that steroids should not be used in CSC. So what we see in this image is an acute central serous chorioretinopathy, where we find a solitary ink blot leak. And generally, the disease is self-limiting, as in this case, at around 2 months, it resolved spontaneously. And the disease is never retinal. Disease is always in the choroid. It's an alteration in the homeostasis of the choroid that gives rise to the disease. And if we are planning to design a treatment, then we should be targeting the choroid. So the treatment need is when the disease is persistent or chronic. So let me show you one of my initial cases where we had a treatment. He was from West Bengal, traveling all along the East Coast to Bhubaneswar for his eye treatment. He had a 7-year history of vision loss in both eyes. And what we see here in this slide is the right and the left eye of the patient, showing features of central serous chorioretinopathy. What you see in the left eye is acute central serous chorioretinopathy features, or according to the New York classification, it's a simple CSC based on the multimodal imaging. Whereas if we look at the right eye, there is a loss of pigmentation at the center of the macula, which is nicely seen on the fundus autofluorescence. And if we go over to the OCT image, we can see that there is loss of RP, which is also known as an RP aperture in chronic CSC. And this can be also supported by the feature of hypertransmission into the choroid. So these eyes generally have very chronic features like intraretinal cystoid changes, and at times also a double layer sign. But this patient didn't have an hyperintense network on OCT angiography, nor there was any hotspot on ICG angiography to support the presence of any neovascularization. Fluorescein angiography, if a novice is looking at it, they might think that this hyperfluorescence is because of a network, but it's all because of the loss of RP there, the RP window or the RP aperture, which is lighting up the underlying choroid and the sclera. So the left eye had leak, as well as the right eye also had a few of the leaks. So since it was the first visit to us, we offered a focal laser treatment for both eyes. The patient returned after 7 months because it was just then the COVID had struck, and the movement across the state borders were prohibited. So 7 months later, we see that the lasered left eye had completely resolved. Of course, it was a simple CSC or form of acute persistent CSC. But the right eye had not resolved at all. So this is when we thought of using PDT, which had been our mainstay of treatment for number of years. But this was the time when the dye was not available in India. So we offered a focal laser treatment again in September 2020. 4 months later, the patient returns with worsening. So this is when we tried a 689 nanometer laser. It's nothing but the laser of the PDT without the dye. So in support of this, there was a nice article in Graphes Archives in 2017, which said that these eyes could be treated with a larger spot of the laser without the dye and yet achieve equivalent results. So we thought of trying this out since we didn't have the dye with us. So 3 months again, there was minimal change in the morphology of the OCT, and we thought we would observe. Again, 3 months later, we offered the same 689 nanometer laser, but we realized that the laser was of no use. In September 2021, we thought of switching the treatment to eplerenone. We all know that eplerenone use is now challenged after the VIXI study results. And we thought if it could work since we didn't have anything else to treat with. But the patient returned again in December 2021 with a similar picture and pleading for treatment. So we didn't know what to do. But that was the time of the year when we published our results of use of dexamethasone implants as an adjunct to anti-VEGF therapy in PCB or pachychoroid disease. So where we proposed that the effect was better because of the chronic inflammation that is there in the choroid. And to support this hypothesis, in the same year, Rick Spade and group had come up with a new hypothesis of the CSC pathogenesis, that is venous overload. So excessive fluid loading in the vitreous generally leads to tissue remodeling thereafter. And this is the region that we get more of the inflammatory mediators in the choroid, like cytokines, matrix metalloproteinases, and integrins. Not only that, there are also evidences of having interleukin 6, 8, 10, 12, and TNF alpha in the aqueous humor of the samples collected from the central serous chorioretinopathy eyes. So this is also known as a retinal parainflammation, which is commonly used in the literature, where we do not see obvious cellular infiltration into the antechamber or anterovitreous phase, but yet we see the signs of inflammation like the edema. So it's nothing but an adaptation to the tissue stress or the malfunction. So this leads to the activation of the innate inflammation in the eye, and which may present as inflammation without the evidence of cells or the clinical evidence of cells in the antechamber or anterovitreous phase. So to test this hypothesis, there have been previous studies like using triamcinolone acetate in central serous chorioretinopathy. So when we thought of testing this hypothesis with use of steroids, we came across just 2 studies, and they are 2 case reports only in the literature, where one of them supported the hypothesis and the other refuted the role of triamcinolone in central serous chorioretinopathy. So possibly triamcinolone was not as potent as the dexamethasone as we always use for other indications for retina. And since dexamethasone's bioavailability is better in the choroid when implanted intravitreally, we thought, why not give it a chance? And we all know that it is that low dose or the constant flow of a low dose dexamethasone in the steroid that suppresses the activated inflammatory genes that results in a clinical outcome when we inject dex into the vitreous cavity. So when we went ahead with a proof of concept study to our ethics committee, they outrightly rejected the idea of injecting steroids into the eye, where we all know that steroids are always contraindicated. But these patients who had no other treatment options, we were already suffering for so many years. And since the evidence was now gathering in the literature suggesting a role of activated innate inflammation, we convinced the ethics committee to go ahead with a proof of concept study. But they said that if you fail in at least one of the cases, we have to stop the study there itself. So we got an approval of trying it out in 10 cases where the treatment was ineffective. All the previous treatments were ineffective. So we chose those cases only who were already treated and had failed. We did not use the eyes which had a good vision of 20/40 or better. We excluded the eyes who had choroidal neovascularization and the eyes which were recently treated with macular photocoagulation. And we had a very strict primary efficacy endpoint that was set at 6 weeks. We believed that if dexamethasone injection is given, then the resolution of SRF should be so dramatic that it should be visible at 6 weeks. So we aimed for a complete resolution of subretinal fluid in CSC when we injected. So December 2021, we convinced the patient about the experimental nature of the drug and inject. So this was the pre-injection picture. 2 weeks later, when we called the patient back for intraocular pressure check, we found that there was barely any change. So we thought maybe we will have to wrap up the study. But when the patient presented at 6 weeks, it was like a moon landing for us, like Chandrayaan-3. So every bit of the fluid had disappeared. The documented evidence of 2 years of persistence of subretinal fluid had now disappeared with a single injection of dexamethasone. Not only that, the vision had also improved. But there was a downside of IOP rise, which was effectively managed with anti-glaucoma medication. But that was the case 2 of our study. The case 1 was a gentleman who had chronic CSC in both eyes, where we could use the right eye as the treatment eye and the left eye as the control eye. So what we see at 6 weeks, although the vision remained the same, but the intraretinal and subretinal fluid reabsorbed. Now I would suggest you to look at the choroid in the subsequent cases that I'm showing you. So we were aiming for the retinal fluid resolution, but to our surprise, the choroid was also resolving. So if we look at the control eye, where no injection was given at 6 weeks, the disease was still persistent. So it said that the drug was very active and it was not worsening CSC as it was previously believed to. So what about in eyes who had a bullous or atypical variant of CSC? This gentleman had almost half of the globe filled with fluid and had multiple areas of choroidal hyperpermeability on ICG angiography. So what we see here is at baseline, the PED and the subretinal fluid. The subretinal fluid disappears completely at 6 weeks post-op, and to our surprise, even the PED disappeared at 5 months. This proves the point that the drug has a good bioavailability in the choroid, and it is the drug which we wanted to target, and it was acting on the choroid well. So in this series, we were fortunate to have 6 of the patients who had a chronic CSC and who had failed with a conventional treatment, and where we found a statistically significant decrease in the subretinal fluid and central subfield thickness. But the visual recovery and the subfoveal choroidal thickness decrease was not significant. But we are almost 1.5 years from the conclusion of this pilot study. We have more number of cases recorded, and we are going to read the paper in VRSI this year, where we saw the effect of the DEX implant in the choroid. So about this particular study, where we had 6 cases, 4 out of the 6 had a complete resolution of subretinal fluid, 2 of them had secondary glaucoma, and 1 of them had a recurrence. So we had an average follow-up of nearly 6 months. So none of these patients had intervortex venous anastomosis, which is believed to be a sure shot sign of a venous overload. So this got published in ISO this year, and in April issue we got the article. So let me show you one of the cases where we had a venous anastomosis and a CSC. And to our luck, this patient was treatment naive and had multiple areas of leakage on fluorescein angiography. Please keep looking at the choroid in this case. So when we treated the eye 2 months later, there was a minimal decrease in the subretinal fluid. But what was appreciable was the reduction in the choroidal thickness. Since the subretinal fluid was still persisting, we offered the patient a second injection of the DEX, and the choroid was also remodeling and the subretinal fluid decreased. So one of the cases of the series which had a recurrence also had a second injection and also showed a similar kind of a resolution. So this says that DEX could be used in chronic CSCR where all other treatments have failed. But we tried it in one of the acute CSC cases where the fluid was persistent. In this particular eye, we didn't have a fluorescein angiography leak, but there was accumulation of fluid in the choroid, which was nicely picked up on ICG angiography. So at 2 weeks, the vision and the subretinal fluid improved, and at 2 months, the architecture of the retina was as normal as a normal eye. So if I wish to summarize it, maybe retinal parainflammation is one of the mechanisms through which CSC occurs, and that is again because of the fluid overload and remodeling that is going on in the choroid. So at times we see acute CSC, but it's already a chronic disease in the choroid. And by the time it manifests in retina as acute form, it is already a chronic disease. That's why inflammation may be a component in the pathomechanism of the CSC. And as of now, as per the study results, we recommend this treatment as a rescue therapy in chronic or complex CSC, where all other treatment modalities have failed.
और पूछे डॉक्टर साहब, आपकी नजरों में हम भी तो चोर बदमाश हैं, फिर उस डाकू को पकड़ने के लिए आपने हम दोनों को क्यों चुना?
इसलिए कि लोहा लोहे को काटता है.
Thank you.
Thanks for very nice presentation. So we are moving to the discussion part.
So I have a question, sir. How do you rate sub-threshold micropulse when you would compare it with dexamethasone? Would you like to try it before, or does it come in your treatment protocol before you decide to inject dexamethasone implant in such a case?
Yeah, of course, you can try subthreshold micropulse laser, and currently we have one study ongoing where we are comparing dexamethasone with subthreshold micropulse laser. So it's a DIA study and it's already approved and CTRI registered.
Did you see any results, sir, in whatever cases you've done till now, and when you compare the two? Any trend you could see?
The results are quite dramatic with the injection. So subthreshold laser efficacy comes much later, and since we choose only the chronic CSC eyes, the resolution is much slower if you have laser as a mode of therapy. So as you have seen in even complex cases of CSC where the intervortex venous anastomosis has already occurred, it's kind of a branch vein occlusion with a lot of collaterals in the eye. So it's that kind of a situation, means the disease has remained in the eye for such a long period of time. Despite that, the DEX implant works. And in those eyes, lasers are a bit inferior to the injection.
Thank you, sir.
Dr. Mesh, I already loved that presentation when you presented in Delhi Retina Forum. So it's my best wishes if you can just bring it as a protocol, as a rescue therapy at the later stage. Fascinating.
Yeah, thank you. We are reading the paper in VRSA this year.
Wonderful.
A larger sample. Thank you.
So I think if we do not have any more questions, we would move on to the next talk. We have with us today a very renowned ophthalmologist. We have Dr. Muhammad Al Amri, President of the MUM Academy. Welcome, Dr. Amri. We all know that ever since we came to know that the inflammatory cascade has such an important role in the pathogenesis of macular edema and whatever cause, be it diabetic macular edema or in retinal vein occlusions. So we have various depot steroids in different forms in our armamentarium to deal with these cases. So Dr. Amri would discuss a very, very interesting topic. He would highlight his experience with fluocinolone acetonide or Iluvien in management of diabetic macular edema. Over to you, Dr. Amri.
Thank you very much for this introduction, and thank you for the kind invitation. Thanks for Dr. Rabhai and Arun Shetty for organizing such an interesting meeting. And I'm sorry for coming late. It was a busy day. So I will go without any further ado. I will go to my presentation. Can you go to the next, please? So as you know, the diabetes mellitus now is growing worldwide, and the incidence of diabetes in UAE also in our area is very high. We used to be ranked as 15th country in the world. During the last few years, after a lot of of work and screening and many things, that's now the prevalence of diabetes we are ranked around 9 worldwide in the percentage of diabetes. And the prevalence of diabetes in UAE in the last, in 2019, found to be around 16%. Next, please. So diabetic retinopathy, as you know, diabetes, it will lead to what we are suffering as an ophthalmologist. It will affect the eye and mainly the retina. So diabetic, and the most important part that we are facing in dealing with diabetes is the complication in the eye is diabetic macular edema. And it's now one of the most common causes of vision loss in patients with diabetes. So all patients with diabetes are at risk of developing DME. So even those they are having even mild non-proliferative diabetic retinopathy, there is a percentage, even in a small number, but they are even they are going to have or may exposed to get diabetic macular edema in a percentage of 3%. That's what the percentage is found. In the USA, the prevalence of macular edema is now around 29% in people with diabetes for 20 years or more. Next, please. So also the prevalence of diabetes mellitus is worldwide. I don't want to go through all this one. I think you are aware of that, and it's really a big hassle for the health authorities all over the world. Can you go next, please? Diabetic retinopathy. This is I want to highlight this point just to reach to our points. In USA, the prevalence of diabetic retinopathy is 17% in person with diabetes for less than 5 years. So even though they are just newly diagnosed, they are 5% of those, or 17% of them, they are eligible to have a diabetic retinopathy. And those they are almost above 15 years, they are having diabetes. They are going to, you see the number is around 97, or you can say 98% with diabetes more than 15, they will have or more. They have proliferative retinopathy barrage. In case of proliferative diabetic retinopathy, it is 1% in person with diabetes less than 10 years, or 67% in person with diabetes for more than 35 years or more. Next, please. Epidemiology of DME, estimated DME prevalence range from around 1% to 12% all people with diabetes. There is some studies was done in UK, and around estimated 7% of people with diabetes had DME. Of an individual, 39% had clinical significant macular edema with visual impairment. DME therapeutic management, the reliable long-term control with Iluvien and a real-world experience. I was lucky, maybe, or I don't know, to be the first user of Iluvien in the Middle East. And since the time that we start, I have almost around more around than 50 case with they receive Iluvien. So there are almost, the male, female, they are a little bit more than male. The mean age around 65 plus minus 13. Around 51 case, each of them is unique. As you know, that DME for every patient is different. Even sometimes one eye to another eye can be a difference. So common to them all that all had received Iluvien implants, post anti-VEGF, and sometimes after steroid challenging test with a good response. Post Iluvien, few eyes had received additional also anti-VEGF as a top-up. Patient had the need follow-up almost every 1 month, 3 months, 6, 9, then year, and 1.5 years, 2 years, and 3 years. As you know, the Iluvien, it can work up to 36 months. When we go and check our patients, these cases, we just review them and we try to find how was the response. We get that the retinal thickness of them, it was dropped very nicely and maintained for a certain period, up most of them we up to 24 months, and then we start showing them recurrence. Some of them, they are having some recurrence in the middle, but the majority, they are starting at 24 months after the injection. Next slide. Visual acuity. Also, most of the time, we found that it is rather than improvement, there is an improvement, but most of the time that we maintain the visual acuity, which is a good if you have a patient that have a good vision, and then you give an Iluvien and 1 injection, and you continue just follow up for more than 3 years without any further, it will be a less cost. So many people, they will talk about the cost, but we can discuss it later. We have some calculation, and we find it even less than what it should be if we are giving only anti-VEGF or other methods of treatments. So some cases, they are improving and also maintaining, which is a very nice response as a DME for this type of treatments. Next, please. So here we are looking for the result of intraocular pressure. I know intraocular pressure is all the time thinking of most of the doctors. They are dealing with treating patient with steroid. But for me, I think we have to come over this point, because you have to balance between what is the benefit. Either you have to say the patient, he will lose the vision because of the diabetic macular edema, and especially if there is some cases they are not responding to anti-VEGF and the other method of treatment like dexamethasone or Ozurdex. So we have to give, a chance for this patient, and we cannot say, okay, if we give, there will be increase in intraocular pressure, and from this point, so we will no. We can't treat the intraocular pressure with one method, and it is only a very small percentage. Around 80% they don't need any treatment. Then around 19% or less, they may need 1 drops or 2 types of drugs to give to manage the increased intraocular pressure, and very less. And even I didn't find, it was found only in the study that there is some cases, which is a very small number, they may reach to need to a glaucoma surgery. So here we found it is very good result with intraocular pressure. We need some only few cases they are need additional or treatment for increased intraocular pressures. For the top-up, around 71% of the patients didn't require any top-up, so we just continue most of them. Patients who require around 29%, they need a top-up. So less than 1/3 of the patients require additional therapy after Iluvien during the follow-up period. Majority of them receive anti-VEGF. Some receive also intravitreal dexamethasone, and I have done some rationale when to use an anti-VEGF or when to use steroid. We can discuss it later on if that's needed. Okay, next, please. I want to share some cases about what we have done. So this is one of the cases. Patient was seen in 2018, and he is a male, 57-year-old. He was diabetic for 14 years. So there is nothing for anterior segment to the normal limit. Both eyes, there is the DME. Right eye was treated with 4 Lucentis and before 2018 and 2 dexamethasone implant in 2019. So then in 2020, in the era of the COVID, as you know, one of the most important also indication to go for long therapy, because it was very difficult. Sometimes there is a lock event, sometimes a block of the hospital. So I give the steroid. And this is the patient, Bree. It was, you can see how it was the vision or the central retinal thickness. And both there was an improvement in the vision and maintains in the reduction of central retinal thickness. Okay, next. This is the Bree injection for this patient. You can see here. Then next, please. So this is how the things run with this patient. So usually in the cases, I want to see the patient after 2 weeks. I want to be sure about everything just to see if the Iluvien in the place, there is nothing is going here, not stuck in the, in the tunnel or something like that. So to be sure about everything. But so can you go back one? Can you go back? Okay. So then 2 weeks, then I have 1 month. You can see there is a drop in the central retinal thickness and improvement 3 months after the injection. Next, please. Next. Then 6 months, you can see almost there is a macular edema, but very less. And then after 15 months, you can see almost dry. 28 months of injection, almost there is no macular edema, and the patient is improving in the vision. Another case, also we can go, the patient was treated 6 anti-VEGF Lucentis in 1 year, then switch to steroid directly to Iluvien. Can you go next, please? Okay, this is how it was pre, and this is how it was post in the vision and in central retinal thickness. Next. Okay, this is how it was the OCT of the patient pre-injection. Next, please. So here you can see the 3 weeks, how it was after 9 months of the patient, 12 months, 13 months. Okay, after that, okay, 17, 18 months. Sometimes, you know, we need not to be hurried to get the result also. Sometimes it takes time. It's more than 6 months to 9 months, but we need in sometimes even to give top up if it is not that much after 6 months. Months plus, okay, 18, 19 months, then it was about 19, then 20, 21. Then after that, you can see months post fluorescein at the last 22. Go next, please. So I think most of you know about Illuvian. I don't want to go through that, but can you go next, please? Next. This is some study that shows the making a comparison, but most of you, I think, aware of that. Don't want to take a lot of time in this one. Go next, please. Okay, so thank you very much. This is what I want to say about my experience in using the Illuvian in treatment of diabetic macular edema. And if there is any comment or questions, I am ready for that. Thank you.
Thank you very much, Dr. Amri. So any questions from any of the panelists or the audience?
Mohammed,
Yep.
Interesting, very interesting, because we do not use it here. So I just was wondering, because that what is the pharmacokinetics of fluocinolone implant? Is it means when it concentration peaks up?
Actually, it is 0.19 milligram delivered every day, daily. So it is a slow releasing, like a dexamethasone, but that one is a high concentration. This is a less concentration, and that one another method. That one dexa, this is a fluocinolone acetonoid. I think it's only the difference.
Yeah, does it has a peak? Does it has a peak of concentration? You know, which we see with the Ozurdex, that it reaches peak, so that we have little more.
No, because this one is like a maintaining, because it's a very slow release. So there was no maintaining, but usually it's give the improvement, we can say, in a 6 months. It is an accumulative effect rather than it is a peak. If we want to say, that's why we say you don't need to do any top up for the patient before 6 months of treatment. If there is no response, you have to give a weight for that. But I don't think there is an amount increase or peak, but it is a slow release, certain amount daily. It is that will be effect and continuous in the same way, but it will be an accumulative effect, rather than it is a peak.
That is what I saw in your first graph, that CRT comes down by 6 months. I think that's where you see problem. Is that the same thing you see with majority of the patients? It takes around 4 or 5 months for
actually
to
most
achieve the
of the
maximum
patients,
brightness.
they don't need, only few patients they need only top up, and especially you are switching to a long therapeutic like Illuvian. After you feel that there is no response from anti-VEGF and also sometimes from dexamethasone, sometimes I'm not using, actually, to be honest, Ozurdex. I can use any other even drop to see if the patient is a steroid responder or not. But because there is two school, if you know the approval of Illuvian, American, they are not thinking about they need to have some steroidal test, while the European, they don't look for that, because the Ozurdex is approved in Europe after the Illuvian. If you know, that's why they don't look to that one. So whatever it is, but the steroid, I'm trying, even sometimes, some of cases, my cases, I feel if the central retinal thickness is high, above 500, 450, 500, I don't go to the anti-VEGF. I go directly to one shot of dexamethasone, and it will bring the central retinal thickness down a lot. Then the Illuvian release, whatever it is released per day, it maintains that one for a long period of time. If the increasing of because sometimes is related to the control of diabetes itself with the patient. Some of them, they are not well controlled and something like that, up and down. This one, it will make that, it will not be similar. So the DME, it will be increased. So if it is little, that not much, so I go to the anti-VEGF. Sometimes it may need 1 or 2 injection maximum.
If I may add to what Dr. Ashish said, it's the famous study which says that the concentration of fluocinolone in the aqueous humor was at its peak during the first 3 months. It was around 2 nanograms per ml, and then it lowered and maintained for the next 36 months at lower, roughly half the concentration, 0.9 to 0.1 nanograms.
Maybe, but
that's
I didn't find in the experience. Maybe this one, it was mentioned. I know it was mentioned in the study. But if you go and use the medication, sometimes there is an improvement, but is it really an improvement because of the steroid itself, because it takes a little bit time to be released and to give the effect, as you know? Or is it really from the previous medication because you are switching to another? Sometimes there is an Ozurdex still, the patient only 4 months now, we are switching, or after 4 months, or anti-VEGF. Because that's why I cannot judge exactly to give an answer about this one.
As per the regulatory, are you allowed to use it as a first line? As per the regulatory?
I have to use it as a first line.
Is it allowed as per the regulatory? Because what I heard was
regulatory, because you have to judge. It should be not.
It's clinician's discretion.
Yeah, but there is an indication, like when you have deal with steroid like dexamethasone, there is you can use it as a primary or before or without anti-VEGF in certain cases. So if this is also applicable, so I say why not applicable in this situation? It is like a comparison rather than it is okay or not, because sometimes I tell you the time of the Illuvian most of the time came in between 2016 and 17 up to 2000 now until now, and majority we start use it in the time of the era of COVID. This year, then it is very important either to give the patient, or he may next time, maybe next visit, there will be a close of the hospital. You are not knowing what you will do. Maybe it will continue for 6 months. That time nobody knows, but and it will open when it closes. We are working in a governmental hospital, so the rules sometimes it's closing everything. So I say, why not to give the patient chance instead of not going? So in some certain cases that force me by itself, no, I have to go and give it. It is a few cases, not that much, but most of the time it's switching after anti-VEGF or dexamethasone.
Thank you.
I had one more doubt, Dr. Amri. It's very rarely reported, but we see cases, we read about cases of viral retinitis, reactivation of toxoplasma after periocular steroids, intravitreal steroids. Now here, since we have a depot steroid which is staying for 36 months, have you ever experienced any kind of adverse effect like that, apart from the rise in IOP and cataract that is known, but any case of infectious retinitis or reactivation, something like that?
To be honest, I didn't face, but it could be happen. It is written and some mention about some certain cases, and mostly after the era of COVID, we are not knowing how it's happened, even not only after the steroid or because of the steroid itself. We faced so many cases after the COVID, after a long period of recovery and everything, then the patient came with certain like detritus or something like that, and you found it is most of the time they are connected to the COVID. But fortunately, I can say I didn't face in all my cases any one of this one. So to give an experience about that, but I didn't face something like that.
Thank you so much. Do we have any more questions? If not, then we move on to the next talk by Dr. Ashish. I request Dr. Avnish to take over. Thank you so much, Dr. Amri. It was an honor to
Thank you very much. Thanks for all, and thanks everyone.
Thank you very
Thanks
much.
a lot.
Thank you so much for this interesting talk. And from the next talk, we have Dr. Ashish Sharma. Sir has no need for any introduction. Sir has completed his Retina Clinical Fellowship from University of California with an additional fellowship from Bascom Palmer Institute, Miami. Sir has been awarded the International Ophthalmologist Education Award by the American Academy of Ophthalmology, and he has been the editorial board member for the high impact ophthalmology journals, and he's also the innovator of our fundus imaging device, MI-RedCam. So over to you, Dr. Ashish Sharma, sir, for your talk on myths and truths about biosimilar anti-VEGFs.
Thank you, Vaibhav and the entire group organizers for having me here. I think we are running a little bit late, so I'll see if I can fast track a bit. So I'm going to talk about the myths and truths related to anti-VEGF biosimilars. I think we are the most mature country as of now if you talk about the anti-VEGF biosimilars across the globe. Before I proceed further, these are my disclosures. So we have been trying to understand biosimilars since last 5 to 6 years, and this is our contribution in the form of various studies where we try to understand, how switching works, how endotoxins works, and how regulatory works. So just to acknowledge me, this is our group of friends, who have been trying to help us in understanding these various aspects related to biosimilars, because now biosimilars are at the global stage as well, since the global patent of Lucent is also expired. So essentially, these are the molecules which are not exactly the copy, because they cannot be the copy, because any biologic, even if the same molecule, they have a different batches, they cannot also be the same. So nobody really say that you have to be exact copy, but yes, regulatory requires that there should not be any clinically meaningful differences. So you have to prove that you are equally potent and you are equally efficacious, and moreover you are equally safe. So why we really need biosimilars? Predominantly you have cost benefit. Why? Because reference molecule takes almost 15 years to manufacture, and around 1/10 of the cost you get a biosimilar molecule. Why cost is a significant factor? I think I don't need to explain that, because we are in a country, and it's not about only India. If you even look at the data of developed world, real world outcomes have always been inferior if you compare with a randomized controlled trial, predominantly because of undertreatment. And why undertreatment? True to the majority of the world that you have affordability issues, limited access to the treatment. And if you really look at Avastin, success of Avastin in a developed country like United States, that itself shows that how important the cost is. Then the question arises that why not bevacizumab if cost is a concern? It is off label. As a country like us, we have seen that we do not have robust compounding pharmacies. We have had some incidences, cluster endophthalmitis, it was banned for some time. So it means nobody wants to take that kind of risk. And many countries like Japan and other countries, they do not allow it to be used. So that's the reason that you need something which is much more cost effective. Now, there are some myths which always keeps on enrolling and revolve around the biosimilars that requires clarification. And this myth starts, I was in Euretina last 3 to 4 days before again. Whenever we talk about biosimilar, always there is a discussion that when India launches first ranibizumab biosimilar, there was some inflammation in the initial batches. That's right. But you should also be seeing that now India has approved 2 more biosimilars in the last 2 years, but there is no inflammation. The reason you should really go and get into the deep roots of that, if you really look at the originator, which is Lucentis, look at the Anchor and Marina data, inflammation was 17.1 and 20.9%. Can you imagine at this point? And now phase 3 trial of SB11, which is actually got approval from FDA and EMA, had inflammation of 0.9%, which is nothing. So now what has happened? So reason is endotoxin limit, which was defined by ISO and what was followed by Resumab when initially they launched it, it was 0.5 EU per ml. But over the time, what happened? US FDA in 2016 or 15, they revised it to 0.2, saying that, posterior segment probably needs a little bit more stricter endotoxin limits in terms of, avoiding inflammation. So once all these companies, they have achieved this endotoxin limits, you do not see inflammation in any of the cases. Even if you look at Lucentis has become much more safer compared to when it was launched. Another myth comes, biosimilars are not tested well in clinical trial. Again, that is wrong. Probably this could be true if you talk about just the, local approval. Local, I mean country approval. For example, trials in India. For example, trials in South Korea, trials in Japan. molecules which are just approved in those particular countries, because those are country needs and country regulatory defines it. But if you look at the FDA and EMA requirement for even biosimilars, the data they need is same as what they needed for the originator if you talk about the phase 3 trial. So interchangeability approval to similarly is the second biosimilar ranibizumab which is approved by US FDA. That itself shows that how much FDA believes in the pharmacoequivalence data. I'll discuss that a little bit later, that why that is important. Myth number 3, that phase 3 trials have very short endpoint. This is, one myth that I always encounter at many platforms, that always it has been said that you have 4 weeks time point, you have 8 weeks endpoint, you have 12 weeks endpoint, which is very short, because as a retina specialist, we are used to seeing big data. But there is a reason, there is a wisdom behind this endpoint. The reason is all the biosimilars, they need to go through an equivalence design of the study. Equivalence design means you need to show that, okay, this is the letter gain, equivalent letter gain compared to the originator, and that you can judge only within that sweet spot of 3 months. You cannot get the equivalence checked at 6 months or a year. So that's the reason that you have endpoints at 8 weeks or 12 weeks, but safety wise the study goes till 12 months. So this myth also is not right. Myth number 4, biosimilars extrapolate approval in all the indications. The reason is the drug is same for the, it targets the same receptors which originator targets. And the major reason is originator has never shown any kind of differential inflammation or differential safety signs compared to biosimilar. So in case if it has shown differential signs for different diseases, regulatory would have definitely asked them to do different trials for different diseases to biosimilars as well. But because it was not shown there, so biosimilar companies, they are required to do only one trial for the same receptors, and then they get approval for all of them except ROP. Now, experience from Europe, if you see, since 2006, none of the biosimilar which has been launched in Europe, forget ophthalmology, because Europe is the most mature nation in terms of overall biosimilar field. None of them has been withdrawn or suspended because of the safety or efficacy reasons. So you need to believe on that regulatory part. Experience from India, Intas Pharma approved in 2015, then Lupin, the Reliance. So these are the 3 major manufacturers. Rest are the marketers. So global biosimilar, you have a lot of other molecules on horizon, and recently last month you have first aflibercept biosimilar approved, which is going to be a major game changer, not only for India but for the entire world, especially India, because we were the only nations which were who were not using Eylea as a primary therapy just because of the cost. Means over the time when this scheme came, our usage has gone up, but still once Eylea biosimilar comes into the play, then probably our entire therapy and our entire treatment protocol would change. So you have a lot of other molecules on pipeline, and you see this is the molecule which I was talking about from Mylan, which already got approval, and 3 more molecules which are already there, already BLA is filed, so they will also receive approval by 2024. So very interesting to see. The most important part for us, me and for the entire world, as far as retina specialists and ophthalmologists are concerned, that we need to really be educated about biosimilars and not see them negatively, because novel assets like brolucizumab could be unpredictable. You have seen Syfovir also. But biosimilar that emulate a product whose safety and efficacy already established, they have very, very rare chance for surprise. So if we believe and if we are educated well, then I'm sure that many lives can become better with biosimilars. Thank you for your kind attention, and thank you, organizer, for having me here.
Thank you so much, sir, for this intriguing talk. So can you tell us, like, since we are having a discussion in India, how good are the biosimilars as compared to the conventional drugs in India as per se? Or do you see any switching more often as compared to the conventional drugs? And secondly, what in contraindication you would want to have for these biosimilars, where you would want to go for more conventional drugs as compared to our the biosimilars? So, is there any indication or a contraindication for that matter for these biosimilars as not using them as the first line of treatment?
So means you need to conventional means you are referring to the originator molecule.
Yeah, right, sir. Right, sir.
Right. So means Lucentis versus biosimilar. So means my practice has completely switched to biosimilar now. So I have no hesitation in using biosimilar. The only thing is, whenever a new molecule comes in, any biosimilar new molecule comes in, then I always go slow. It's not about only biosimilar. Any new molecule comes in, I always go slow. It's not like, you just go with all the guns and start using it. But there is no contraindication as such.
Any other questions from the other moderators and the panelists here?
Are you using it in ROP, Dr. Ashish, biosimilars?
No, actually, my practice does not have ROP, but it means our colleagues, they are using it. Allah uses it very well.
Thank you.
Any other questions we have?
Yeah, Dr. Ashish, wonderful and crisp talk. So, how do you choose between different companies? Means, what is your favorite? Let me ask you, ranibizumab biosimilar.
Yeah, because that's actually on all the forums, that is a major question which is being asked from us, that out of them, which one do you choose? So to be frank, primary therapy as of now, we choose Resumab all the time because that is the one which has gained the highest experience. And now we are publishing a data of RENI-Eyes. We have gained good experience with RENI-Eyes, around 500 patients data, injection data we are publishing. So it's all about, the gaining the experience. So as of now, overall out of biosimilars, first choice is Resumab, second is RENI-Eyes, and third is probably, Ranizorel, which means we used it when we were having the study, real world data study for that, but our experience is limited. So as of now, I'm using 2.
Thank you.
So if you don't have any questions, can we call in off for this session, sir?
Yeah, I think I thank all the panelists, all the speakers, all the audience for such an exciting session. I think we can conclude the session now. So thanks to Dr. Vaibhav of Ophthalmologica, and thank you again to all the speakers. Thank you very much.
Okay, have a good night, everyone.
Thank you very much. Have a nice day.
Please.